I think I've got a little bit. I was like, you look familiar because I said this picture. It's nice to meet you.
Plenty of time to hear from Ashley. I'm glad everyone really digs the change, the variety. So just feedback to whoever switched it up for us. That was really great. Okay. You guys
ready? Sorry.
Done chatting amongst yourselves. No, it's cool. So it's my pleasure to introduce Ashley Jenkins today. She is a med-peds physician who's been focused on transitions in the earlier part of her career. And like most med-peds people, the thing that I initially noticed about her CV was basically she's been doing bilateral things for everything. So she had internal medicine and pediatrics. She also did a hospital medicine fellowship and a health services research, a general academic health services researcher. And so now I think she's going to talk about two sides of transition.
Hi everyone, thanks for having me here in Boston. It's been a lot of fun getting to talk with folks so far. So yesterday I was at Brigham and talking about the medicine side, and you guys and some people like Craig who go a little more in between both in research. So yeah, I'll be talking about some healthcare transitions for young adults with chronic conditions. So, the usual start of my professional background, so I give a lay of the land of where I've been there. So I actually did my undergraduate degree at Brown, so not too far from here, in Boston, a fair amount. Concentrated in international relations and biology. I wasn't one of those people that always knew that I wanted to do medicine. Knew that I think I always was interested in why people chose to do the things that they do and why different countries did different things and different policies. But I also was really interested in biology and puzzles and people's health. So all of those things combined together, I always went into medicine knowing that I would want to use my medical degree to do other things that would help impact people's lives and help people's lives be better in some way. So that led me to go to Eastern Virginia Medical School, which was both in-state for me because my family landed in Virginia. And also they are a medical school that was actually developed and fundraised and created by the community in the 1970s and really had a mission for community outreach, which was particularly important to me in veterinary medicine. And I like to think that I had the insight that mentorship was important in med school. I didn't think about it quite that way, but decided I wanted to do a med-peds residency. And EMS didn't have a med-peds residency. There were a couple of subspecialists who had done it, but I knew I wanted to be at a place that there were lots of people who had done med-peds and I could see how they were using their careers in different ways. So that's how I ended up in Cincinnati. And then through residency, I started off with some usual stuff. We're doing some small QI work in our clinic, had an opportunity to work with NAPA in Cincinnati on some discharge literacy, or improving the discharge literacy of instructions when people are leaving the hospital. And then going into a med-peds chief year, we got to go to what I call EBM camp at Duke. And as I learned more about essentially evidence-based medicine, how to teach it, all of that sort of came together, and I was realizing, I'm actually really interested in understanding how we know what we know, and that if we have questions that might impact patient care that we feel like haven't been answered yet, then how can we actually ask them and answer them in a meaningful way? And had some pretty awesome mentors, including Joe Toole in my med-peds residency program, and I know a lot of you guys know her here, especially through IPAS work. Really was helpful in thinking through that a research fellowship would probably be a good idea, and being able to house that in hospital medicine as a med-peds person would be a good opportunity. And so then Karen Girardi was awesome since to really allow me to create my own fellowship. That then was housed in hospital medicine, had to encourage them to be able to align some of my interests as health services research with some strengths in our Jenkins division as well. And so then through all this, getting a master's in clinical and translational research, which is similar to some of the programming you have here in terms of foundational biostatistical and immunologic methods, as well as then some focus on some other methods I'm going to talk about too. And then the other piece, as far as my personal background, that I think is important and informs how I think about the world, This could just be a story of someone who was born outside of Chicago, so I was born in Naperville, Illinois, and landed in Cincinnati for residency. So I've just been a person who's been in the Midwest, stayed in the Midwest. But actually through my formative years, I actually spent a good amount of my time growing up overseas, navigating between different countries, cultures, and schools. And that made me what we call a third culture kid. That's something which you guys are familiar with, and that my identity is in part informed by where I was born in America, but also the places that I've been and the places where I currently am. And as I was reflecting on this, like, well, maybe it's not a surprise then that in my career that I'm also in a role where I'm navigating different cultures of healthcare, in terms of medicine, pediatrics, and honestly, hospital medicine. For those of you guys who are hospitals, we interface with different cultures of healthcare all the time. Like, I think the surgeons, like, they are a totally different culture than I am as a medicine doc, but we're all a part of sort of the same units of healthcare. And I just want you guys to think for yourself for a moment, for the patients that you provide care for, or for those of you guys who aren't doing clinical care, of the people that you're trying to help with your work and your advocacy, how much of someone's health do you think is dependent on how they navigate through a healthcare system? I think that I'm confronted every day with how much of someone's health is dependent on how they navigate through their healthcare system. And I find it challenging navigating between these different cultures of healthcare and the healthcare system. And after the end of all of this, I'll have had 12 years of medical and research training, and I still find it hard. So I can't help but thinking, what about our patients? And then what about our patients who are adolescents and young adults who are having to go back and forth potentially between pediatric and adult healthcare systems? And I want you to think a little bit too about someone's life course trajectory. So in the US, most people are going to live to somewhere in their mid-70s. If you think that every person when they're born, let's just say that they're going to interface with a pediatric healthcare system, there are there's consensus that by age 21, for the most part, you should probably have left the pediatric system to go into an adult system. So what does that mean? That means that 28% of your life may be interfacing with the pediatric system, versus then 72% is in an adult healthcare system. And so I think that that has implications not only then for the pediatric system that is bringing in patients that will ultimately have to leave their system, but then also for the adult system that's actually going to be caring for these patients potentially for the majority of their life. And then the other thing I want you guys to think about too is that transition is really a normal part of development. So all of us in this room, I don't think there are any kids, have, technically speaking, transitioned to adulthood, hopefully somewhat successfully. And really that's been a process of planned movement from adolescence to adulthood. So this is a normal thing that then becomes more complicated depending on the issues of the person. So keeping that idea of transition with you, inpatient versus outpatient, pediatric versus adult care, this is what we're doing to our patients in terms of what they're having to navigate through and potentially having to bridge. So it's with all of that in mind that I really feel like I have a mission at this point to be able to optimize equitable healthcare access and delivery for adolescents and young adults who are having conditions originating in childhood. And it's kind of with that mission in mind that it's informed some of the projects that I've done and then some of my future directions as well. So the first project that I want to talk about is one looking at the health needs of people with spina bifida in Cincinnati in the process of transitioning to adulthood. I want you to meet Danielle. She's 24. She lives in Cincinnati and has spina bifida. She's also a part of the research team that I helped lead for this project. Briefly considering her life trajectory. A child born with spina bifida can have varying levels of spinal cord deformity, pictures on the right, and depending on the severity of that malformation, they're going to have a wide variety in terms of the medical comorbidities that come with that and how that affects their health over time. And you can imagine that that requires multidisciplinary care to keep them healthy, and you guys have a multidisciplinary clinic here for patients with spina bifida. But this also then leads to challenges as people with spina bifida get older in terms of having functional independence, being engaged with the community, and also as they get older with their sexual health and having reproductive challenges. But all are different things and different health issues related to health that change over time throughout the life course. And what do we know in terms of needs of people who are transitioning to adulthood with chronic conditions? So I'd say we know that there is a lot of unmet needs, and there's a lot of literature that shows this. I'm just highlighting some of them. The first are that there are just normal developmental complexities of being an adolescent, of being a teenager. But for people that do have a chronic condition, we know that they have increasing medical comorbidity with age, more mental health problems, there are lots of changes or even loss of insurance, and then things that I think that can be particularly frustrating is that there really is a lack of effective and evidence-based interventions in thinking about promoting and really having a successful transition. And so you might say, okay, Ashley, you just went through a list of all the unmet needs that you already know exist. Why the heck would you do a needs assessment in Cincinnati looking at what the needs were? What we found in Cincinnati was that we knew that people weren't having their needs met, but we didn't know how our local community actually prioritized those needs and really where to start first. And so it's both for us to validate within our own community what the barriers and facilitators of a successful transition were, but to also prioritize what those issues were to figure out where to start. And within that, then we had two sub-aims. The first was we wanted to use this project as a way to identify ways of effectively engaging people with spina bifida in research. This is already hard enough to engage young adults or adolescents in their health, much less than in research that's hopefully going to improve their health. So we wanted to use this as sort of a test case of ways to do that. And then also wanted to make sure that everything we did with this project really was with the lens of how is this going to inform intervention development. And then as far as the context, besides just being in the city of Cincinnati, Cincinnati Children's has a Center for Spina Bifida, and it's a multidisciplinary clinic that's existed for some time. And then we have the Spina Bifida Coalition of Cincinnati. Both of these players had had an informal relationship to provide family and patient supports in the healthcare setting, but they were really wanting to move forward with doing research together and potentially designing interventions, but what they didn't have was research expertise. And so I came along as newly minted hospital medicine fellow who had done some coursework in community-based participatory research and was really excited about using those methods. And so we had the opportunity to work together to write for a small partnership development grant to do this needs assessment and to really figure out how to work together and try to develop a academic community research partnership. The method that we decided to use was called concept mapping. Concept mapping is a community-based participatory research method, and so we really wanted to actually use a participatory research method, in part because some of these methods really are designed to iteratively involve multiple stakeholders through the research process and continue to get feedback on the results that you're getting. And then within this, there are three phases. The first is a generally qualitative phase, where it's a generation of a list of ideas. The second part is kind of a mixed qualitative and quantitative component, where you actually identify broad concepts in those ideas and then map them. And then the last phase is quantitative in terms of actually prioritizing the topics of importance to the community. And then within this method, then there are multiple steps. The first is preparation, then there's generating ideas, sorting, cluster map analysis, grading and ranking. In the preparation phase, part of this had already been started in terms of trying to identify needs for a successful transition. But the other part of preparation that we had to go back and make sure we did was that had we really appropriately identified all of our stakeholders, our study population. So clearly we wanted to be able to engage individuals with spina bifida. We started making sure at age 12, and then we did not have an upper limit of age, feeling that everyone would have input in terms of what helped make them a healthy adult. But then for people with spina bifida, our different groups including parents and primary caregivers, community and advocacy organizations, and then pediatric and adult healthcare providers. And then we also made sure that our research team reflected representation from each of these member groups. And that's actually, at this point, we had everyone in the box. We did not have a person with spina bifida. And there were a lot of reasons for that, but that's ultimately how we were able to get Danielle involved in our work as well. So now moving to generating ideas. The way this starts, usually you have one open-ended prompt. So we started with, to be a healthy adult living with spina bifida, I believe I need to change the pronouns based on what we were actually asking. What we found, though, is that when we tested this out with kids with spina bifida, so 12-year-olds with spina bifida, or even some of our 20-year-olds who have executive dysfunction and intellectual disability, this was a little too open-ended. So we actually added 2 additional prompts that our team felt got at what people needed to be, or needed to have to be healthy adults. That surrounded financial security and being an empowered member of the community. And so from there, we asked folks to generate ideas. And similar to other qualitative work, we set to the minimum number of people that we thought we wanted to make sure we reached out to. So we started off with 15 people from each stakeholder group, but then we iteratively went back to check the ideas that were being generated and didn't stop recruiting people to participate until we weren't getting any new ideas. So ultimately, we had 579 responses from 98 participants. What I mostly want to point out is that we did relatively oversample from people with spina bifida, but the reason was we kept getting new ideas. Whereas honestly, after talking with adult and pediatric providers, after talking with like 5 people, like we got all the ideas that the providers were going to offer, which I think for me was a really key learning point, you know, of you had to make sure you had the right people at the table asking the questions and answering them, else you're going to miss stuff. Like if we just had physicians at the table, we would have missed, I think, a lot of really important ideas that impact the health for people with spina bifida. And so some examples, first was respect, ask if I need help, a job that allows me to live where I want, and the things that needs to maintain a healthy mental state. And then you can imagine that we wanted an exhaustive list of ideas, that we also had a lot of redundancy. So our research team did need to go back and look through all the ideas and make sure that we just had a unique collection of ideas. So here I want to give an example of how we combined some things. So there were a lot about knowing or being taught how to navigate the healthcare system, making your own doctor appointments. So this got combined into skills for navigating the healthcare system, such as making doctor's appointments. So to recap, we had 579 responses. We whittled this down to 90 unique ideas. For this method and thinking about, you know, participant response burden later on, usually you want this to be under 100. But you do want usually above 60 and 70, or else you're probably not generating enough ideas. And then now we were ready to get at the underlying issues. And this is where sorting came into play. And the way I think about sorting is that it's a relatively easy way of anyone who doesn't have sort of research background to take a bunch of ideas and sort them in a way that makes sense. And there are a couple of different ways you can do it. We decided to use an online platform called Optimal Workshop. And there are ways you can physically do this with cards. So all of our participants would see this welcome screen in terms of just reminding them what this study was about. And then I'm going to walk you through a brief example of how they would have done this. So on the left-hand side are all the 90 unique ideas that we had whittled down, and then on the right were instructions for the participant. I'm just going to go with a sample of 5. So first, the person would click on one of the ideas. So here would be education around how to handle common spina bifida incidents when they occur in public. If you're like me, you don't know what a spina bifida incident is. So a lot of people with spina bifida have neurogenic bowel and bladder, and so even if you're doing the best with all of their medicines and regimen, they may still have episodes of incontinence in public. And so there needs to just be a lot of education and understanding of like, what do you do? Like making sure you pack, you know, an extra bag of clothes, things like that. So that's what that means and what they meant by that idea. So then what they would decide for these next ideas is whether to bucket it in the same group as this one around spina bifida incidents or put it in a different group. So this participant thought that these 2 ideas were similar, but then coordinated comprehensive medical care, they thought represented a different group or idea. We'll continue to do this with each of the 90 ideas. The last thing that we asked them to do, and you don't always have to do this in this sorting step, is we actually asked them to name the groups because we wanted that additional qualitative element to understand what people were thinking when they grouped things together. So this person got the one on the left, they needed healthy sexual development, and the one on the right is medical home. So ultimately, we asked 5 people from each of the stakeholder groups to do the sorting. So we had 25 people total that sorted all 90 ideas. So from here, this is where we went to cluster map analysis. And within cluster map analysis, there are 2 parts of that as well. The first is multidimensional scaling, and the second is hierarchical cluster analysis. And I'll walk through really briefly what's involved in those methods, but happy to answer more specific questions later. What to know about multidimensional scaling is that essentially this helps us create a map of all of those 90 ideas by really creating points of their relative positions that is determined by how similar or dissimilar those items were sorted together or not together. And then this generates an XY coordinate for each of those ideas. So it allows us to create this. So this is a 90-point map, and all of those points represent all of the 90 ideas that we had asked people to sort. It's helpful to have axes on there. I put them, but it's not like one is positive and one is negative. What's more important is the distance between the points. To demonstrate a little bit more about what that means, that these 2 points, participate in medical care from a young age as appropriate, or coordinated comprehensive medical care, you could potentially see why those 2 points are closer together and that people tended to sort them together. Versus ability to move freely in my community without barriers is a point further away on the map, suggesting that people were sorting these ideas separately or differently. There also are ways to make sure that your map actually has reasonable fit, and this is something called a stress measure. So for this 90-item two-dimensional map, we wanted our stress measure to be less than 0.392 to suggest that people were actually sorting all of these ideas in a particular pattern or way. But anyway, okay, well, you've got 90 points on the map. How is that helpful? So we're actually then able to move forward to see how participants tended to sort these things together. And that's through hierarchical cluster analysis that allows us to get this. So the cluster map, I think what's important to understand is that you could either have one cluster that everyone sorted everything together, or you could have up to 90 because everyone thought that they were different. In general, what you want to be able to have is a cluster map somewhere between 5 and 15 clusters, because you're wanting to understand what are the concepts that these ideas actually need. So there is a qualitative component that our team went through of really looking at, all right, we have these different cluster options, what are the ideas within them, what do we think they need, and how will that inform our future work? So I'm going to walk you through then what we thought those concepts were. So the first were skills to maximize independence, inclusivity and supports, physical accessibility of the environment, employment, finances, community and school-based resources, coordinated and comprehensive medical care, health and wellness, self-advocacy, and self-management. The other thing that I personally like about this data visualization and way of thinking about the data is that just like any map, you can also interpret it in different ways. So one way is through each of the concepts, but another way when we were looking at this is that there also seemed to be two domains, if you will. One that we felt was more of the healthcare domain, and one that we're calling an advocacy domain. And the way to frame this and why we would think about it this way is that within the coordinated comprehensive medical care, there was participated healthcare early, so the bottom green one. And we felt like this was something that clearly fell within the purview of the healthcare team in the clinic. The interventions could be designed to actually address this. Versus something like a job that provides a living wage without affecting public assistance programs such as Medicaid, while clearly important to promote health for patients or people with spina bifida, may not be something that the healthcare team or that the center and the coalition would directly do in terms of the intervention that they might co-design. So it was helpful for us to think through the information in this way as we're thinking about next steps. And I'd just like to point out too, especially for the point about public assistance programs, insurance, and how that affects independence and employment for people with disabilities, there's just been more and more that I've been seeing both in different blogs and platforms really talking about how much of an issue that is for people living with disability. So next steps for this work, that actually when I get back to Cincinnati this week, we'll be wrapping up this data, is that we've asked everyone, all of our stakeholders again, to rate and rank all of the concepts by importance and feasibility with the hope that we identify some go zone areas as far as where priorities align. And then once again, to be able to present it back to different community members to get feedback. And then the other thing that, before I move on, is with this project, we've also then had the ability to really interact and meet with different community organizations that are very interested in partnering in future work. And so I think that's been the other power of using this participatory method in generating ideas. The other thing for me as a fellow and being able to learn honestly from Danielle, to talk with her about her healthcare experience and honestly just her transition to adulthood. So we've actually talked a lot about her difficulty in finding stable employment with benefits, independent housing. But she also didn't know what a hospitalist was, and so some of the things we talked about, like, were my clinical role. But also she didn't know, and still there's uncertainty about if she was sick enough to be in the hospital, where would she go? She's 24 and she has spina bifida. I want you guys to think for yourself, do you know if she needed to be hospitalized? Like if she was in Boston, where would she go? And what if I told you that for her bowel and spinal cord care, she saw an adult subspecialist, but for her bladder and for her BP shunt, she was still seeing pediatric subspecialists? Would that change your mind about if she needed to be hospitalized, where she would go? And so it was with kind of these questions in mind and my own experience in Cincinnati, where these sorts of things would actually impact where she was hospitalized, depending on what's going on with her, that led to work thinking about where adolescents and young adults actually being hospitalized across the country with certain chronic conditions. And what do we know about this so far? So it was some earlier work that did show that adolescents and young adults with certain chronic conditions are hospitalized in pediatric and adult systems. And I think we know that anecdotally in terms of what clinicians see day to day. But in pediatric hospitals specifically, there were some projections that for adults who had certain chronic conditions, that population was expected to continue to grow in pediatric settings, but also account for more charges, inpatient days, and readmissions than their younger comparative populations. And this group of people was also expected to have an increasing prevalence of other chronic conditions as well. So I created a conceptual framework to help me think about some of these questions, and that you can have an adolescent or young adult who has a chronic condition, they can develop an acute care need that requires hospitalization. And then you can think about their care setting potentially as having some branch points in terms of decisions. That you can go to a pediatric hospital, like Freestanding Children's Hospital or Boston Children's, you can go to an adult hospital, potentially like Brigham. But that's not always how binary it is. So sometimes you have an institution, potentially like Mass General, where you actually have adult services and pediatric services. So it's kind of thinking of those kind of care models in mind that I thought it would be helpful to actually see where people were getting care and starting to chip away at what factors actually direct these kind of pathways in terms of where people are hospitalized. So aim one of this work is descriptive in terms of looking at how does hospital type use change by age. And aim two is to look at what patient level factors affect this pathway. And then aim three is to look at how national guidelines may have actually had an effect on the transition age of where people are getting, where adolescents and young adults are getting admitted. So aim one was to determine the frequency of hospitalizations for adolescents and young adults, or AYA, with specific chronic conditions of childhood that occur at pediatric hospitals versus then adult hospitals with pediatric services and adult hospitals without pediatric services. I'll walk you through why I have that breakdown of hospital type. But first, we did a cross-sectional analysis of hospitalizations in 2016 using the National Inpatient Sample. So that's a public nationally representative administrative database that has data from 47 states, over 7 million discharges. It's agnostic of payer or chronic condition. So being able to leverage this national data set with a lot of numbers to be able to get a sense of where people were going when they were being admitted. Population they just look at were AYA ages 12 to 35. And I focused on 3 specific chronic conditions, cystic fibrosis, congenital heart disease, and sickle cell disease. The rationale behind that is that these really are conditions that affect the whole lifespan, require some specialty care, and also have evidence of higher hospital utilization as well. And then we use ICD-10 codes to identify patients with these conditions. And then for the analysis, it weighted estimates based on the sampling design, and then used chi-square and will concentrate some tests depending on the nature of the variable to look at patient clinical characteristics. Now for hospital type categorization, I'm going to walk you through how I did it and why, but it's actually because of issues with hospital type categorization that I've gotten to work a little bit with Jay Berry here, and some people also looking at the National Inpatient Sample to look at where adolescents and young adults are being hospitalized. Because since 2012, NIST has not actually had hospital identifiers in terms of knowing what a hospital is or if it's a pediatric hospital. So we were able to use data from the Children's Hospital Association Case Mix Index database to actually look at pediatric hospitals to see the number of discharges that were pediatric aged and then the percentage of those discharges that were pediatric aged to create this categorization scheme. So the first step was that if a hospital's total annual pediatric aged admissions were less than 1,500, we categorize this as an adult hospital without pediatric services. To be a hospital with pediatric services, you then first had to have more than 1,500 pediatric aged admissions, and then from there we looked at the proportion of pediatric admissions to total admissions. So if you're greater than or equal to 88%, that's categorized as a pediatric hospital, and if less than 88%, it's an adult hospital with pediatric services. So practically, what does this mean? So an adult hospital without pediatric services would be something like Brigham. Boston Children's would be a pediatric hospital, and then Mass Gen would probably be categorized within an adult hospital with pediatric services. We identified 78 pediatric hospitals, 1,036 adult hospitals with pediatric services, and 3,461 adult hospitals without pediatric services. And then as far as the number of admissions, we had 25,374 unweighted admissions for AYA with these three conditions. And then walking through some of the clinical characteristics. So first starting with percentage of admissions. So pediatric hospitals had 11% admissions for AYA with those three conditions versus 68% in adult hospitals with pediatric services and 21% in adult hospitals without. Looking at age, not surprisingly, pediatric hospitals had a lower median age than adult hospitals. Looking by sex, pediatric hospitals had a lower prevalence of female patients compared to both adult hospital types. And then looking at payer mix, adult hospitals had a higher percentage of patients with Medicare compared to pediatric hospitals, as well as then a lower prevalence of private insurance compared to pediatric hospitals. And then looking at the income breakdown, there was a higher prevalence of patients who were in the lowest neighborhood median income brackets at adult hospitals with pediatric services compared to pediatric hospitals. So now looking at how hospital type use changed by age. So on the x-axis we have age, y-axis percent of total admissions. It occurs for three different hospital types. So pink are pediatric hospitals, green are adult hospitals without pediatric services, and blue are adult hospitals with pediatric services. And what you can see here is that the biggest change is between the ages of 16 and 21, which honestly is as you might expect, right? When we might think that people might be leaving pediatric hospitals and entering adult hospitals for their hospital care. We'll say we can't say that that is what is happening, in terms of what these particular patients are doing, but it might suggest that. But I was curious about, did this vary by chronic condition? Going into this, my hypothesis had been, knowing a lot of the work that's been done with the CF Foundation and transition work in that space, is that for patients with cystic fibrosis, I expected that they may have left pediatric systems by an earlier age than patients with congenital heart disease or sickle cell disease. That's what I thought when I started. But looking at pediatric hospitals, and now the color lines have changed. So red is sickle cell disease, green is cystic fibrosis, and blue is congenital heart disease. They were all, they look about the same. So ages 16 to 21, the biggest decrease in the percent of total admissions. And then by age 22, things have really plateaued. To be honest, I was somewhat surprised, knowing my experience in Cincinnati, perhaps maybe Grace's experience here. Anyway, who are older than 21, only 1% of their hospitalizations were in pediatric hospitals. I couldn't give you a percentage that I might have expected. I actually just thought it would be more than 1%. But the other thing that I noticed here, and it becomes a little more pronounced looking at other hospital types, is that instead of this being a story about the difference between cystic fibrosis and the other conditions, that this might be more a story of how maybe the healthcare delivery landscape for sickle cell disease might look different than the other two conditions. So looking at adult hospitals with pediatric services, again, biggest change is between the ages of 16 and 21. Plateauing at 22 and older. So for AYA who were older than 21, 72% of the hospitalizations were in this hospital type with pediatric services. And again, seeing a little bit of spread potentially in the percent of total admissions that are happening at adult hospitals with pediatric services for patients with sickle cell disease versus the other two conditions. And then finally, for adult hospitals without pediatric services, again, same pattern as far as where you're seeing the changes in percent of total admissions. Ultimately, AYA who are older than 21 had 27% of their hospitalizations in adult hospitals without pediatric services. Then seeing potentially a bigger difference in the percent of total admissions at this hospital type for patients with sickle cell disease. So to recap, only 1% of hospitalizations for, I say older young adults, but I know that sounds a little weird, were in pediatric hospitals. But this still does amount to about 1,000 admissions for AYA older than 21, just with these chronic conditions that are being hospitalized in pediatric hospitals. So in some ways, you know, and I'm still grappling with this too, like, is any number appropriate? I'm not sure. But then looking at the patterns of hospital type use, it really seems like perhaps there are some differences by condition. And so for AIM-2, what I wanted to do was first look to see if chronic condition was associated with the type of hospital used, and in particular for AYA who were older than 21 in pediatric hospitals, and then adjusting for other patient level factors we have access to within this database. What I found is that if you have congenital heart disease or cystic fibrosis, you have much higher odds of being admitted to a pediatric hospital than if you had sickle cell disease. So just another way is of quantifying what I got to seeing on those figures I showed you before. But then what about all those other patient level factors that I adjusted for to try to look at the association of chronic condition? You know, walking through some of the characteristics again, and these are for patients in pediatric hospitals. Definitely for patients with sickle cell disease, there's a higher prevalence of Medicaid, also a higher prevalence of Medicare, but also higher prevalence of patients who have lower, who live in neighborhoods with lower median income, higher prevalence of urbanicity. But then kind of stuck with two conditions as well that have a higher prevalence of white versus Black race. And so it's become challenging to think about how can I look at some of these patient level factors and if they affect what type of hospitals used when this happens, or when this is part of the reality of patients with these conditions. So what I plan to do is actually create 3 different models within each condition to then be able to test for association of the sociodemographic factors on the hospital type that's used. I think the challenge that I'm running into right now is that there really just aren't a lot of older patients who are being hospitalized in pediatric settings, and especially just with these conditions. So I may still just pivot to some conditions that have more numbers, so patients with type 1 diabetes or things like that, to try to get at whether some of these sociodemographic factors are impacting where someone's hospitalized. And then finally, this part is also still in process, but the goal is to be able to look over the last 20 years if certain transition guidelines or clinical care mandates have had an effect on the age that someone is transitioning their inpatient care. And the one that I was most interested in exploring is that knowing that in the early 2000s, the CF Foundation, in conjunction with some other professional organizations, really said you have to have a particular care model that includes transition in order to be a pediatric or an adult CF center. And thought that perhaps this might actually have led to bigger changes in terms of transition efforts than some other just more broad guidelines regarding transition. The plan for this is that be able to do an interrupted time series analysis pre and post the 2004 guideline to see if there's been a change in the age of transition. So thinking of all that together, what I do want to be clear is that I don't necessarily think that the age of transition is the outcome to follow in terms of whether someone's had a successful transition. I just think that it's one potential outcome that we could use to try to see from a population level how things are going and how we're doing. And I say that in part because I had the opportunity to work with some folks in Cincinnati, essentially just look at what had gone well and what hadn't in terms of transition efforts over the last decade. These folks were trying to actually develop an epilepsy transition clinic. So trying to be like, well, what were the lessons learned then? What they found is that there are definitely individual components, you know, of a person that may facilitate or be a barrier to their transition in terms of self-management, how much they know about their condition, all these sorts of things. But there were also really health system barriers. There were some facilitators, but they're mostly barriers within the health system in terms of transition efforts. So some have to do with financial support in terms of actually paying for the services that someone who's helping with that transition do. There's a lot of practice variability. What if the physician who treats XYZ neurologic condition says, I'll keep people forever, but then you have a provider in GI who's like, nope, I don't want to see patients once they're past the age of 18 or 21. It makes it really challenging from a system level to do something. Insurance is a problem. So pediatric systems, especially freestanding children's hospitals, tend to take most insurance, right? So you may be one of the only games in town, or at least in Cincinnati, that's the case. But that's not always the case for adult systems. And so how do you make connections if your academic adult center has providers who take different payers? Billing is an issue. So there's actually a fair amount of evidence that doing a warm handoff actually helps promote patients actually being seen by their new adult subspecialists. Get both specialists in the room, see the patient together, do an introduction, like that will happen. But then who pays for the clinic and the space, and who gets to bill for that visit? All that stuff gets in the way. And then as a med peds person, so, you know, it's often said, oh great, you know, you're med peds, like you're gonna help lead the way with transition stuff. And I mean, I absolutely wanna be a part of that. But what happens when something is champion dependent? This champion walks around, goes from building to building, makes the phone call, knows the people, gets people connected. But what happens when that person goes? When that person goes, at best things just stagnate, but at worst they dissipate. And what my hope is that we can really start thinking about how do we create infrastructure and linkages within healthcare systems so it's not so champion dependent. Because otherwise, whose responsibility is this? Right now, I would say that it's really, we're making it the responsibility of the patient and their families. And then they have to have the access, opportunity, and education to do it. I think that it's our responsibility in the healthcare system to do it, because I think that we've created healthcare systems that make people have to do this. So future ideas for a career development award. One place as a hospitalist that I think might be important to really understand are really what are the perceptions and experiences of pediatric versus adult inpatient care. So if we don't understand what each system is doing better or worse, or what a patient and family might expect, then we're not going to prepare them well for this transition. I've talked with a few of you guys already think about, are there ways that we can actually measure and analyze the network relationships between adolescents and young adults and their healthcare team members during transition, and look at the effects on utilization and retention and care and their health through this transition period. Another thing that I've become also increasingly interested in is really trying to understand how factors like changes in insurance coverage affect healthcare access, retention, and utilization during transition for AYA with chronic conditions. I think that there's going to be huge opportunity as claims database work continues to evolve to really tackle this question. I was talking to you earlier about why this has been challenging to do beforehand, and especially for adolescents and young adults, because they're having so many changes in insurance, or they're changing healthcare systems, or potentially they're even moving states. It's really hard to actually follow people longitudinally to see how these things actually impact their health. And then I'm also really interested in thinking about, in this work, how it can really be co-produced with patients and families and lots of other stakeholders. So imagining a world where we can actually co-design an inpatient care pathway that would help people on an individual level determine where the best place was for them to seek care. What if it wasn't just pediatric versus adult, but that a person, right, has a problem that needs to be dealt with in a particular way, and you're able to actually see what your system can provide versus another one. And as far as potential funding sources, I'm probably, it may be a little overly optimistic, but I do think that transition efforts are being funded with increasing frequency, and that really interdisciplinary work is being thought of as pretty important to tackle lots of different healthcare problems. But NHLBI is definitely of interest for me, especially since some of my work already with cystic fibrosis and sickle cell disease and John Parkinson's would fall within that. As a hospitalist and systems thinker, ARC is always appealing. And then NICHD came out with their strategic plan for 2020, listing transition as one of their 6 key priority areas. And in particular, looking at care models and outcomes that could be followed. So I think that is also a potential opportunity. And then there are also a lot of different foundational awards and other young investigator grants that have been supportive of this kind of work as well. And then we've acknowledged this list could be a lot longer, but I've just been really, really fortunate to have an amazing mentorship team, and I can't say enough about my career mentors through my various scholarship programs. So thank you for having me, and I'd love to have any questions or comments.
Actually, I think it's great. I know we talked a little bit more, but I think one of the things that I think is most interesting is about this disentangling location of care with type of care. I think a lot of guidelines will say, pediatric hospitals, pediatric patients go to pediatric hospitals, adult patients go to adult hospitals. And so in some ways, pediatric freestanding children's hospitals and adult primary hospitals are hamstrung because they can have their way. But when it comes to this population, in some ways, an adult hospital with a pediatric service might be the ideal place, but it may not be either. And I think by cutting very granularly and say, this is the location, guidelines miss sort of the quality of care, the type of care they experience. So I think this idea of identifying, thinking about experiences of inpatient care from the hospital's perspective, I think is critical. Yeah, it really hasn't been done. I think, taking the CF example is a good one. The CF Foundation, they put their line in the sand that says, if you're over 21, you should be in an adult hospital. There are definitely institutions, ours among them, that have tried to develop models that actually more focus on the type of care than just the location of care. That comes contrary to that. So I think understanding those experiences is really a great thing. Some more of a comment than a question.
Well, I think too, to your point as well about some of the different challenges that might exist when there is a pediatric hospital or a unit within a larger adult institution, that there are still going to be different challenges there, but what might be easier there in terms of, well, okay, you could be an adult service, but you don't have child life come to you, or that subspecialist could still be with a hospitalist service versus something like that is a little more complicated when you have two separate institutions as well.
I have a question about more where you think you're headed given where you've been so far.
Yeah.
So can you go back to your statement about equitable? So can you say a little more about what you mean by equitable?
Yeah.
Because it just it seems to me that you've used chronic condition in different ways, and you're comparing several different factors a lot. And so which one how do you think about it, and which equity do you care about the most?
Yeah, it's a good question, obviously, and one that I'm grappling with. I think when I say this right now, where I'm coming from is that I think that by not addressing transition in a systematic way at a higher kind of population health level and health systems level, that we may actually be exacerbating health disparities for particular patients. And so some of this has been informed by for me as a person who takes care of patients, for instance, with sickle cell disease in the adult healthcare setting, and working with a lot of them in terms of what their transition experience has been like versus patients with other conditions. So I think that for me, I'm still figuring out how much I don't know, I'm not going to explain this well because I'm still grappling with it myself, but I think that thinking about equity and what we're doing in the transition space for any of it is going to just be incredibly important. So that's why I have it as a part of.
So it's it sounds to me like a double equity issue. One is that you care about these populations that have not just chronic, we're not talking about just asthma, we're talking about complex chronic conditions relative perhaps to folks who do not have those conditions. Or is it I don't think the care is good enough in one setting, so coming from a pediatric perspective and being a center of excellence around sickle cell, all these conditions, they're not going to get as good in a non-pediatric focused environment. So there's and then kind of a third layer where with the spina bifida work, you picked out healthy people with only spina bifida, not with their usual set of comorbid conditions that make them even more complex.
So we actually did have relatively complex patients with spina bifida involved in the work, and we actually then involved them in different ways.
You got the folks who don't have intellectual disability.
No, we didn't.
Oh, I misheard you.
Yeah, no, we didn't.
Okay.
Yeah, I said that we tried to do things to optimize through that process, to actually be able to get, information, ideas and information from them. So we definitely included that.
Sorry, I just.
Oh, no, that's okay. No, and that was actually something we really struggled with, through that process of wanting to do the best we could to make it accessible. So, for instance, we have a lot of the things our community partners ended up doing through Zoom, and so for the idea generation, that they do a lot of things with both teens and young adults, that they would, gave them the opportunity to respond individually, but a lot of them actually need a lot of coaching and help to actually respond to the prompts. So we try to do different things like that. Yeah. So as far as the equity piece, then yes. So I think I understand your question. To frame it in how I answer. So I think from the equity piece, there's a lot of different components. There's the disability components, and disability is then a huge term too. There's the racial component in terms of how that even comes out by different conditions and how research dollars and infrastructure and things like that may have been put in different areas. And then I really struggle with where, and could use some ideas if you guys do, as far as really how to start looking at what is the quality of care for certain conditions. Because I do wonder if there's a little bit of the perception sometimes that one, on the adult side or on the ped side, that care here is better, and on the other side it's not. And I don't know if that's true or not, and if that's really where the focus should be, or if it should be on how to leverage what we think are the strengths of different systems and help people make decisions about how to get care in those settings if that's right for them.
Okay, so so that level of equity is the demographic differences among people who have these hallmark conditions. That's a future thing. It's not something you're doing now, but you wanted to understand the transition, and then it might differ depending on whatever your demographic is.
Yes, that's part of it.
Oh, part of it.
Yeah.
Yes.
I apologize for having to step out. I actually had to step out for a transition-related matter, inpatient to outpatient, not
hey, well, we can still last.
But before I had to step out, one thing that I was intrigued by was early in your presentation, you were talking about how you could kind of come up with these two reframings around financial security and then around empowerment in the community setting. I don't know if you go back to that slide, but I was just curious in hearing a little more about how you arrived on those two domains.
Yeah. So that took a lot of time with our team. I say our research team, but it's me, Jason Woodward, who's the medical director of the Spina Bifida Center, Rhonda Morrison, who's the executive director of the Spina Bifida Coalition, and her background's in social work, and then Diane Burns, who is a program manager, but also a mom of a college-age woman with spina bifida, and then with Danielle, actually, although that was a little bit later as we were finishing the prompts, just to be transparent. And we had a lot of back and forth, and we actually trialed it with a lot of different people to figure out what were the right things to ask. And so the reasons why is that there were things that kept coming up in different settings, really about ability to manage finances and insurance and things related that all were jumbled together, that when we asked about finances, people actually were kind of answering that. And then really it was our community partners that really wanted to think about empowerment in there. They're like, this is just so important for health and community engagement, and we think that this gets at what it means to be a healthy adult. And what I found was interesting, and I think to share, is that looking at people's responses to each of the prompts, we asked them in different orders for different people, just kind of with survey stuff to make sure we weren't just priming people with each question. Everyone gave us similar ideas in each of the different buckets. So I hope that answers your question, how we got there, but also that I actually feel that it was right. We also went into it that if we were really getting different answers from each of the prompts, then we would have done this process for each of the prompts. Right. But because there really was such overlap in terms of our intent of getting at what to be a healthy adult, then we kept it together.
Yeah, it's so interesting because you weren't actually asking about health, yet you got all these domains that actually really answered the questions that you were probably trying to get. The other thing I was going to say was I was really struck and impressed by the extent to which you really authentically involved parents and caregivers and the patients themselves throughout all stages. So congrats on
that was our community. I mean, I think just that was our community partners too. I mentioned we did our part with the providers, and I got on the phone with DDS and things like that to get different participants. But I mean, that's the thing, right? They're engaging with patients all the time in lots of different ways. So it was incredible working with them.
So I have a question. So on your study where you looked at where individuals with 3 diseases got care with age.
Yeah.
So I was thinking about those 3 diseases. I wonder from that perspective, knowing how individuals with each diagnosis and what happens to them as they get older. They're very similar. So it would make sense that it was similar over time between them. Because if not, then that might be more, whether they had access to a different type of hospital, so they have to go to, say, a hospital. a freestanding pediatric hospital. We're just trying to get a way that you can use those diagnoses to disentangle what might be driving.
Yeah, I think, so are you, can I just make sure I'm understanding your question? So you're saying with those three conditions that perhaps in terms of what we might expect of how they should actually be accessing healthcare, like with pediatric subspecialties and how those diseases progress, that you might just expect to actually see similar patterns.
Because all their
Yeah.
health concerns at age 40 are kind of similar. They would shift to an adult provider. They would not be issues that would be more well suited at a pediatric setting. Are they all similar that way?
Oh, you're asking if they are, okay.
Yeah, so is it that kind of confirms what you're finding?
So I think that I would maybe say yes and no. I think at the older ages, it's a little easier to say that, right? Like when we really know the incidence of cardiovascular disease, goes up, or diabetes, or kind of these other things that we know come up in adulthood. But I do wonder a little bit if some of the other trajectories during transition for some patients might be a little bit different. I think that I don't know other than to say right now that these are the kinds of hospitals that they're being hospitalized in. I don't necessarily know what's really like causing that to happen. I think the other piece that I thought might lead to differences is that, and I couldn't look at it in this data set, is how your proximity to a pediatric hospital or institution might affect where you get care. So my thought had been, or hypothesis was that since most patients with sickle cell disease actually live in urban settings, that they actually might be just a little later in their transition because they have easier access to pediatric institutions versus, especially for cystic fibrosis and congenital heart disease, you do have more people who live in rural areas and may have to travel farther. So that was what some ways that I was thinking of, there might be some differences.
It's hospital discharge data too, so you don't have any particular window into the outpatient part that contains some of the comorbidities.
Yeah.
Okay.
The other thing I've been thinking about too is that, how much does who you're actually getting subspecialty care from direct where you're hospitalized as well. I think, again, the key things that I've been excited to talk with people about in terms of databases that do follow people longitudinally and that you're able to see those aspects of their care to be able to start answering some of those questions. Well, thank you. And if you have any other questions, please let me know.